Hello, my name is Dr. Sehdev. I'm a medical oncologist at the Ottawa Hospital Cancer Centre, and I'm pleased to today present a discussion about priority access for Canadian patients with cancer to comprehensive genomic profiling. This meeting is organized by Impact Medicom. In terms of my disclosures, I've received previous travel and conference support from Foundation Medicine several years ago on one occasion, and have done a fair bit of pro bono advocacy work in this area in order to get better access for our patients. This report was developed by Impact Medicom, and the steering committee guidance provided by numerous respected medical clinicians in this field, including medical oncologists listed here, pathologist Dr. Brandon Sheffield, also Jim Slater, a former chief provincial diagnostics officer from British Columbia. Funding support was obtained also from Roche, from AstraZeneca, and from Illumina. A full version of this report can be found on the Impact Medicom website with the address listed here, and it can also be found by scanning the icon on the right. So in terms of an introduction as to why this topic is quite important, I'd like to walk you through what this testing involves and why, as clinicians, we have a desperate need for it in an increasing number of cancer patients. So technological advances have exposed multiple new targets for potentially effective cancer therapy and reveal the importance of the tumor's genomic makeup in helping to better predict what treatments will work for a patient. Precision medicine and precision oncology involve finding the right treatment for the right patient at the right time. Currently in Canada, we have over 20 cancer therapies linked to over 15 genomic biomarkers, so genomic aberrations or identified features that can better direct therapy for patients. So comprehensive understandings of a tumor's genomic profile are currently really needed to select optimal therapy. In the diagram below, you can see multiple common cancers listed in dark blue, and in light blue are listed numerous genomic aberrations that can be detected now, sometimes through laborious single-shot older methods, and sometimes through comprehensive genomic profiling panels, where we have effective therapies. In the dark blue lines, link the cancer to the aberration and explain where we already have effective therapies, although not always having access to the testing to identify the patients. And in the dotted red lines, we have connections outlining areas under active investigation, where we soon will have more options for patients. Currently, several tools can identify genomic biomarkers to direct therapy, although often we've been using single gene or hotspot testing, a test identifying or looking for one particular target genomic aberration. There are limitations of those tests that can be better addressed with these newer comprehensive genomic profilings, or CGP for short. And we have an urgent need for payers, both private and governmental, to develop frameworks for incorporating this into their funding decisions for what they will fund to support treatment recommendations. So in a standard single hotspot test, we laboriously can look sometimes for one particular aberration, but we use up a fair bit of tissue, and it's often quite difficult to do invasive, uncomfortable biopsies repeatedly for a patient to study many different aberrations. For this report, CGP is defined as a molecular diagnostic test that uses next-generation sequencing technology, where we simultaneously can identify the four major classes of genomic alterations that we now are looking for. On the left, you can identify substitutions, and for those without a biology background, our DNA encodes for our proteins and our life really through a combination of these nucleotide bases and base pairs. And if one is substituted with another through a mutation, that can lead to defective production of proteins, aberrant signaling, and carcinogenesis, or change the behavior of cancer. In insertions and deletions within that gene, a large block of coding, of DNA coding, is inserted, or a large chunk deleted that again changes the coded signal that's made by that gene and can be very detrimental. In gene amplification, one particular gene copy can be duplicated where many copies can exist and they can then amplify the signal created out of proportion to need. And in gene fusions, two genes that normally are not juxtaposed can be mutated and juxtaposed together so that one perhaps can even activate the other and lead to aberrant protein expression and carcinogenesis. The gene fusion is one of the first ones we identified as a driver of cancer, the so-called BCR-ABL fusion that is the hallmark of chronic myelogenous leukemia. And to illustrate the advances we've made, an oral pill targeting that particular fusion abnormality called imatinib is probably one of the biggest advances in oncology in the last 20 years, revolutionizing that kind of leukemia from an often fatal disease within a couple of years now to one patients are living with often for their whole life with a functional cure. This technology can identify all relevant genomic biomarkers for a given tumor type that we're looking for and can be rapidly adapted as a platform to include new biomarkers as they become discovered and relevant. So advantages of this kind of testing include decreased turnaround time that can be done quite quickly and simultaneously for the various markers we're looking at. So it's much more efficient, requiring much less tissue. Again, it can be impossible to get more and more tissue from patients. It's also complete because it simultaneously can look for those four classes I outlined. It's sensitive because it can pick up small amounts of aberrant genomic aberrations that we're looking for that may otherwise elude older tests. And it's also adaptable because we can again add to this platform of testing with minimal impact on cost or turnaround time. And we also can do these tests using blood samples, not using tumor samples. So we can repeatedly assay patients' blood or look for tiny needles in a haystack of tumor DNA floating in blood that can give us the answers we need. So in summary, our steering committee has multiple recommendations that I'll walk you through. The first one is that all patients with advanced cancers should have access to CGP where deemed necessary or valuable by their clinicians. Clinicians in Canada tend to look for these tests or utilize them very responsibly only if they're actionable and can meaningfully change a patient's outcome. They're not usually done as a hunting expedition. Number two, tumor types, particularly that have at least 5 genomic biomarkers that already have linked approved therapies, i.e. they're actionable. By finding those biomarkers, we can do something about them to meaningfully improve our patient care. They should be prioritized for access to this kind of testing to replace our currently limited modalities. Number three, we should be cognizant of other tumor types where we're approaching that 5 biomarker threshold. Maybe we're not quite there yet. And so in some of those diseases, doing single tests sequentially may be acceptable, but we should be able to respond quickly in our policies and funding decisions to adapt when they come on board. Number four, any patient who has refractory disease that's gone through all proven therapies for which the condition might seem hopeless, or they're lacking therapy options for in a disease where we don't have good therapies, they should be prioritized for CGP testing to help guide either treatment or identification of clinical trials that might be suitable for them. And number five, we'd like to establish a new framework for really assessing the effectiveness and value of CGP testing using clinical trial designs that are somewhat non-traditional, that are more appropriate for this kind of technology. So number one, all patients really should have access where deemed by their clinicians. Remember, the patients often have a very poor prognosis with advanced cancers and require drug therapy to help improve survival. Some of these drug therapies now have revolutionized our field. We have oral therapies for metastatic melanoma that previously used to be a very rapidly fatal disease that are keeping patients going now for many, many years, sometimes even allowing for cure. I thought that would never happen when I was younger in my training. In some types of lung cancer, one pill a day can control the disease now in the very long term for patients with the appropriate genomic biomarker. Also, in the middle portion, we're identifying that many tumor-agnostic therapies may be coming on board. In these situations, we have a therapy that works for a particular genomic aberration, but it may work in any kind of cancer. not just a particular disease one by one. So if we find that aberration, one therapy may be approved to apply regardless of the cancer type. And we have to find the aberration to allow our patients to have access to that. Number three, the economic benefit in this situation continues to grow. The more therapies we have, the more biomarkers that are available, the more at the end of the day, we will have a cost-effective option. Some of these treatments can cost $5,000 to $10,000 a month, and it's a shame for a test that costs a few $100s to be a barrier to patients accessing these types of treatments. 7 out of 15 of the most common cancers now in Canada already have over 4 biomarkers recommended in international guidelines to be tested for to guide treatment decision making. We have plenty of supportive trials. They'll be listed in tables throughout my presentation and accessible also in our references, and the actual trials can be obtained for you if interested. But these trials show that in a prospective clinical trial design, that if we find the right aberration and target that effectively, we can dramatically improve patient outcomes. When evaluating this type of methodology, we have to remember that the current standard of care, level 1 evidence to guide approval for drug therapy, is not always feasible. We may not be able to demand that kind of evidence to approve testing modalities. In level 1 evidence, we have usually phase 3 clinical trials that often involve more than 1,000 patients where half get one treatment and half get a standard of care or a different treatment. And we often have to wait for a few years to see if their overall survival is meaningfully changed. If we're looking at rarer patient subtypes with, let's say, a common cancer, but a rare genomic aberration, it can be very challenging to, in global studies, find that large number of patients to do randomized trials for. And we have to be able to adapt to different types of trial evidence, phase 2 studies, studies looking at response rates, progression-free survival, endpoints that can be collected very quickly, where they may show very promising and dramatic improvements over standards of care. And we have to be able to adapt that. On the diagram on the right, it's reminding me to talk about other testing examples. So in the 80s, when I was a student, CT scans that are shown on the left were about $400 a test. And in 80s dollars, that was a lot of money. It often was a barrier to getting them done. But we didn't wait for studies showing that by doing a CT, you would improve survival or long-term outcomes. It was inherently obvious that a better understanding of where the cancer was, how fast it was growing, would help us better treat it. And those tests were rapidly brought into practice, subsequently MRIs, PET scans. Currently, CGP testing in today's dollars is approaching that same value, that same number. So again, it's kind of a shame that we are not able to get the genomic fingerprint of the cancer. We really need to have that picture of its biology to guide our decision making. Recommendation 2. Currently, we should particularly prioritize for testing diseases that have at least 5 or more genomic biomarkers that are linked to approved therapies that we can use for our patients. This type of testing is much more cost and time efficient and tissue sparing. If we have to do one test, that takes about 2 weeks at minimum to get a result. And if it's not negative, apply a second test up to a 5th test. That can take months. Our patients don't have that amount of time. We really have to critically identify the optimal therapy for them. And again, we can't keep going back into small tumors with invasive needle biopsies, for example, to get that tissue. Examples of diseases now that fit this definition: lung cancer, colorectal cancer, and breast cancer, which are amongst the 3 biggest causes of cancer and death in Canada, and cancer of unknown primary, a disease where the cancer manifests with metastatic spread, but the origin, where it came from, is not always clear. So in lung cancer, as an example, it accounts for 1/4 of all deaths with a relatively poor 5-year survival rate, although it's improving with new therapies. We have 5 genomic biomarkers currently linked to Health Canada approved therapies, yet the testing to identify the patient for those treatments can be very challenging. CGP has been shown to be associated with improved outcomes. So by doing the testing and identifying the right patient for the right treatment, the overall population may have a better survival outcome. There are wide disparities in access to testing now by jurisdiction, by patients' ability to pay, by insurance variations, and by provincial jurisdictions in terms of their approach to funding. This now is a major problem for us. And overall, we have noticed that there's a positive or neutral economic impact versus standard testing. So this type of CGP testing seems to be cost effective and the most efficient way to rapidly find the targets we're looking for. Here are an example table really of 5 genomic aberrations that are already ready for prime time that we test for now. The testing is often inefficient, done sequentially. That takes quite a bit of time. My colleague, Dr. David Stewart, has done a lot of research documenting through mathematical modeling how many patients in the world and in Canada die because they're waiting for test results or can't get on therapy fast enough. These are treatments that I've used in practice already that have been dramatically effective. And there are many more emerging biomarkers that are almost ready for prime time. I won't belabor you with the biology of these markers, but the top 2 are being actively researched currently. Tumor mutation burden reflects how mutated the entire genome is. If a cancer is related to a very carcinogenic mutational cause like smoking or ultraviolet radiation, they often have a lot of mutations. Those mutations generate unusual proteins that the body can recognize through our immune system, and immune checkpoint inhibitors there can be dramatically effective. So we have many more emerging biomarkers just on the horizon. So benefits of therapy, again, with CGP, rapid testing, identification of actionable alterations that we can do something about, and our ability to find these often by so-called liquid biopsies or blood biopsies that basically involve taking a blood sample and catching that little bit of tumor DNA in the blood to better identify the right treatment. Without this kind of information, we have to go to old school toxic chemotherapy and see if it works and then revisit these options later. If we can identify the better treatments for the patients without having to go through chemotherapy, we can save time, make sure patients do get the right treatment quickly before they succumb to their cancer, and avoid chemotherapy side effects. Again, we have many supportive trials showing the efficacy of this type of testing, the cost compared to the value of therapy, and showing better outcomes by having access for lung cancer patients. The economic feasibility, one Canadian study from the Princess Margaret Cancer Centre in Toronto found that the incremental cost by doing CGP was quite modest. Remember, our drugs are costing sometimes $10,000 a month nowadays, dramatically improving patient outcomes. But we don't want to be limited by the relatively modest cost of testing, so we can't get through the gate to offer these to our patients. There's about 7,600 patients per year in Canada, we estimate, with lung cancer that will be optimal candidates for CGP testing. These are patients with metastatic cancer who are fit enough and willing to receive therapy. So what about colorectal cancer? Colorectal cancer is now the second leading cause of cancer death in Canada. There are currently at least 6 biomarkers identified that are linked to Canadian approved therapies, many under investigation. Again, we have the option of avoiding costly, toxic, and ineffective empiric therapies that we otherwise would have to give. And also, by having access, we can really properly follow international guidelines for what optimal care should be. Optimal care nowadays includes offering, for example, immunotherapy to some patients that have the right biomarker profile, or targeted therapies, not chemotherapy, depending on the genes identified. We currently can't offer that in Canada without access to testing. So these are examples. The top several I mentioned, KRAS, NRAS, and BRAF. Wild type means normal. If they're mutated, we know that the 2 drugs listed, monoclonal antibodies, will not be effective. But if they're not mutated, then we can use these drugs with good effect. Microsatellite instability reflects to, again, a mutational impact of cancer cells. If they have that feature, and 4 or 5% of a common cancer is a lot of patients, we know that pembrolizumab or immune therapy can be even more effective. That drug is approved in many countries for this cancer just on the basis of finding microsatellite instability. You'll see this term NTRK come up in many cancers. It's one of those tumor-agnostic biomarkers we're looking for. It's a particular gene fusion that can occur at low frequency with many cancers. But if it is found, we have these two oral drug therapies that can be remarkably effective, that can really change a patient's world and survival. Emerging biomarkers are listed here. I won't belabor them completely, but BRAF really should be ready for prime time today. We have drugs that are able to target that. And the ones below, HER2 is around the corner, and tumor mutation burden, again, can identify patients for immune therapies. There are estimated to be about 5,400 patients in Canada per year with colorectal cancer that will be eligible for this type of testing. What about breast cancer? I treat breast cancer, and I know sometimes we really have a need for better testing to guide our treatments. It's the second most common diagnosed cancer in Canada across both genders. And some types, particularly triple negative breast cancer, cancer that's not responsive to estrogen or progesterone or HER2 targeted therapies. In other words, we only have chemo to offer them. They have a particularly poor prognosis. There are currently 5 genomic biomarkers, again linked to Health Canada approved therapies, and many more under investigation. And patients with this cancer have a significant unmet need for better therapies. So BRCA1 and BRCA2 are mutations that either can be inherited, the one that Angelina Jolie famously had, that can lead to breast cancer. And for those patients, either if they have a mutation in their cancer or one they've inherited, certain types of chemotherapy are more effective, platinum-based chemotherapy. And oral PARP inhibitors, olaparib and talazoparib, are oral targeted therapies, are also much more effective than standard therapies. Currently, we have great difficulty finding these patients. We only can test for patients who inherited the cancer, and only if they have a strong family history to qualify for traditional inherited cancer testing profiles. PIK3CA is a mutation which is fairly common in metastatic breast cancer, in the most common variety, the estrogen-sensitive type. And there we have the drug alpelisib, an oral therapy. We currently can get it funded compassionately by the manufacturer, where it's been shown to improve survival in a phase 3 randomized trial. So we're really desperate to find these patients, but access to testing currently is limited, only really as part of research studies. So we should be looking for those in everybody. The bottom one, ESR1, is a mutation in the estrogen receptor gene, very common with ongoing treatment. And if we find that mutation, we know we can use different types of estrogen receptor modulators or anti-estrogens that will work more effectively for our patients. We don't really have access to these types of tests in most of our patients. And in a sense, it's a travesty. We're getting quite far behind the modern world in this respect. There are multiple other biomarkers, again, particularly AKT1, that we are developing drugs for that are just around the corner. So for breast cancer, there's about 2,500 patients we estimate in Canada that will be eligible for this type of testing. Cancer of unknown primary is a very challenging area. It's where cancers present with widespread metastatic disease, where the mother tumor, the primary, is not evident based on physical examination or routine body scans. These patients, pound for pound, have a much poorer prognosis. Currently, CGP testing allows us to look for particular targeted therapies that might help these patients. And also, in a good number of patients, we can identify their diagnosis. We can tell where their cancer came from, and then perhaps expose them more logically to therapies used for that particular disease. There are about 6,800 patients in Canada. We estimate that this would be a very appropriate testing for. So our third recommendation for diseases where we're approaching this 5 biomarker threshold, we should have systems and policies in place so we can rapidly open the doors to allow for funded testing and not have to spend 1 or 2 years debating them at committee levels. We have to keep pace with this rapidly evolving field. We have drugs that are coming on board very effectively and rapidly, yet we don't have the rapidity of mechanisms to approve access to these tests. Having access will really help to narrow that gap between the availability of therapies to help and access to the tests. When EGFR targeted pills came out for non-small cell lung cancer, they revolutionized the field. They became the optimal first therapy for patients with that mutation. But it took almost 2 years for most Canadian jurisdictions to find a way to standardly publicly fund that test to identify those patients. I remember that vividly. These types of CGP tests can also better match patients to trials, clinical trials. Even if we don't yet have a proven therapy, we can offer patients clinical trials of very promising approaches so they have a chance at benefit. This is a list of multiple common cancers, including bladder cancer. In bladder cancer, patients with FGFR aberrations we know benefit from erdafitinib and other FGFR targeted oral therapies. In melanoma, we have numerous new biomarkers coming on board that will be targetable. And in prostate cancer, also a very common cancer, we're finding numerous mutations, homologous repair deficiency mutations, for example, that can guide our therapy with currently available treatments. And we need to have access to tests to identify them. For recommendation 4, we should prioritize access to testing for patients who don't have any proven effective treatment for their cancers or where we've run out of treatments. There are patients nowadays that have many lines of therapy that still have a good performance status, so they're healthy enough to have more therapy, but we don't yet have anything to offer them. And by doing CGP selectively in those patients, we can again identify clinical trials for them and perhaps offer them therapies matched to that genomic aberration. So we can expand their treatment options. We can use therapies that are proven for that aberration, but perhaps used in other cancers routinely, better identify a personalized treatment plan. These rare tumors represent a small number of patients, so the budget impact of testing there is modest and potentially has a high return in terms of impact on innovation, being able to identify clinical trials, direct patients to adequate research, and really change the outcomes for their cancers. Examples of patients who would be good candidates for this: patients with advanced incurable cancers, refractory to standard therapies after already having them, fit enough and willing to receive targeted matched therapies. In general, I'd like these types of patients to be presented at tumor boards to get a consensus from our experts in each cancer center that this type of testing is reasonable, and also to review at molecular tumor boards the results we find to get a consensus from experts in molecular science as to what targeted therapy we might reasonably and more effectively offer patients. Recommendation 5, we need to have that framework to rapidly review data and allow adoption of CGP using less traditional methodologies. For example, we have to be able to look at real-world data. Again, finding that level 1 evidence, that phase 3 trial with multiple years of follow-up will be very challenging when we have these rare diseases or rare subsets of common cancers where these aberrations are uncommon. Cumulatively, all the aberrations in lung cancer represent a big chunk of lung cancer patients, but individually they're small. And looking at real-world evidence, even endpoints such as progression-free survival, response rates, not the classic endpoints of survival, allow us to adapt to evidence more rapidly. We should also be able to consider innovative reimbursement models such as managed entry agreements. If we have therapies that are very costly, in order to better accept the risk trade-off financially, many jurisdictions, particularly in Europe, including France, have these types of reimbursement models where the risk to governments or reimbursement funding bodies is taken into account. So if a drug doesn't work, there's some give back and give and take that goes into the overall cost for the country and trade-offs. And that type of wheeling and dealing is essential to allow early adoption. Multi-stakeholder collaboration is very important. And again, we have to be able to look at these non-traditional study designs. Examples of 2 designs that are particularly well suited to this field include umbrella trials and basket trials. So umbrella trials basically involve one cancer disease. Here pictured is lung cancer. But the patients identified have multiple different genomic aberrations. So in that trial, everyone with lung cancer with the genomic aberration is included, but the patients are assigned the drug to match that particular target that's found. In a basket trial, it's kind of the opposite. You have one genomic aberration of interest where the therapy we think or we know will work for that aberration, but it can occur in many different common cancers. So you take a basket of patients with multiple different cancers, but they share the common biomarker, and you treat them all with the same drug, and you look at the efficacy. And that's how drugs like larotrectinib and entrectinib for that NTRK aberration have come to be developed so rapidly. These are examples of basket trial designs. I won't belabor the details, but these are biomarkers under investigation in basket trial settings in multiple jurisdictions across the world. We need to really have some communication between regulators and HTA bodies to ensure equitable access to these types of therapies. Canadians really insist on fairness. I think we are proud of our medical system, the fact that we have a common framework around funding and access to treatments. But increasingly, the reality is that we live in a two-tiered system currently. If someone can afford the cost of a test, which can range from a few $100s to $6,000, they can get perhaps better care and better outcomes. If they can afford a drug that's not yet been funded, our funding processes with government can take a year or two, then they may have better outcomes. And in practice, I've seen that, unfortunately, all the time. So we need to do better than we are doing. As far as testing, testing funding is not controlled or approved the same way that drugs are. We have new drug funding programs in Ontario and in many provinces to look at evidence. We have PCODER and CADA processes to review where ideally a new drug will fit. We don't really have that for testing. We have health technology assessment bodies that look at this, but their processes are different and vary from jurisdiction to jurisdiction. So agencies providing support and guidance include those listed from the FDA, the British NHS, and the European Unmet HTA. And these links can take you to recommendations for how we should really be carefully appraising this type of field. So in summary and conclusion, cancer treatments have shifted from a one-size-fits-all approach to precision medicine strategies where a genomic fingerprint is central in determining optimal treatment. Canadians with cancer need access responsibly to where it really counts, where it really can change our outcomes, to accurate and efficient CGP testing. The access should be a priority for all patients with advanced incurable metastatic cancers, and further prioritization of access should be based on cost utility. For example, tumor types with already having 5 biomarker therapy linkages, or patients with unmet need, where they're really desperate and we need to find something for them. That should be the priority. Lastly, I think the value versus the investment will continue to increase as we have more and more effective therapies and more clinical trials to offer our patients. So the need for CGP will expand very quickly. I think we're really quite far behind in Canada in identifying a rapid framework to look at this type of testing. When I talk to panels of oncologists about our needs, what our problems in giving cancer therapy currently are, uniformly, and this has been true for several years now, the biggest complaint or concern we have is that we don't have rapid testing, rapid access to molecular testing to guide our therapy. Many of us, frankly, feel rather embarrassed by that. Unfortunately, it's an area where government has lagged. Our processes for government funding have fallen behind, and we really need to look to other potential models and also to look to private insurance coverage of such tests, and eventually having tests come down in price where patients can also potentially afford therapies. So thank you for your interest in this area. To visit the full report, you can visit the website listed, impactmedicom.com/publications/reports. And I'm hoping this discussion today will have piqued your interest in this field and will help accelerate access for our patients to this very important technology. So thank you again for your interest.